سامعني حبيبي؟
نعم هلا سامعك، تفضل.
ممتاز. شايفني؟ أنا شايفك.
لا لحد هسه لا مش شايفك.
شو لازم أسوي هسه؟ في شيء لازم أسويه مور
فيديو.
ريكورد لا هي فيديو هيك فيديو.
ايوه
أيوه ممتاز.
بدله كمان احرجتنا.
لا ما بقدر جامد. شباب احنا متعودين على بعض هاي بس بنجهز حالنا نعمل بروفا.
اهلا وسهلا اهلا وسهلا.
اهلا وسهلا حبيبي. هو احنا لو قلنا بس على الشباب تاعونا كان ما في مشكله، بس في ناس اليوم راح يكونوا 2 3 4 اكثر. ابصر
ان
كم
شاء
واحد
الله ان شاء الله.
ان شاء رب العالمين حبيبي. هيك الامور جاهزه نعمل تيست على السلايدز ولا؟
هاي لسه الناس تدخل، وثاني شيء تنساش انه الساعه 6 يمكن يطلع صوت السماعات.
طب عندي ميوت بريك يعني هذا هيك برجع الصوت. هسه رجع الصوت.
Dr. Saad for organizing this. I think the idea to start a series of talks. We'll start with the approach to spine deformities. Then Dr. Firas will talk about the most common type, which is the AIS or adolescent idiopathic scoliosis. I think we have then to continue with the series of the deformity later on to talk about early onset scoliosis and degenerative scoliosis later on. And after that, we will start to discuss cases. I think this is the best for surgeons who are in quarantine and they are doing no surgeries at this stage, just to share knowledge with each other. And today will be about approach to spine deformities. And the objective of this talk is just to know the different types of spine deformities and the most common classifications of each one, if they have any classification, and give an introduction on how to approach any spine deformity in the clinic. So if we start with this kid, he is a 7-year-old boy presented with back asymmetry with no neurological deficit. As you can see the asymmetry of the scapulas. If you can look here, you can see a little bending of the spine. You can see there's an asymmetry of the shoulders from the back, and you can see the hump when you are looking from the side. So this is the X-ray. This is to remind you just only a 7-year-old with a 50 thoracic and 40 lumbar curve. Regarding the kyphotic angle, looks normal, and here the CT scan, you can see that there is no any abnormality in the spine, which means it is not a congenital. So I will come back later after I've discussed this case with you. So the first thing, why we should treat spine deformity. This is not a plastic thing, not because we have a crooked spine, we have to straighten it. It is it's a chronic disease, so you have to follow up your patient. It is associated with respiratory insufficiency and sometimes failure, respiratory failure in high angles if it is reached more than 100 degrees. It is also associated with low life quality. Sometimes deformities are painful, sometimes prevent patients from sitting in good position, and self-image of the girls who have such a deformity. So these are the definitions that I just would like to go before to go through the deformities. If we are talking about scoliosis, in the past, it's just only lateral bending. Now we know that lateral bending is not the only deformities. Always look at the alignment and look at the rotation. So if we have a lateral bending in the spine more than 10 degrees, this is a definition of scoliosis, but pay attention to the rotation and sagittal malalignment. Sometimes it's associated with hypo or hyperkyphosis. Usually the kyphosis is a normal sagittal alignment, as we know, in the thoracic and the sacral spine, but it is abnormal in cervical and lumbar spine, and hyperkyphosis when we have abnormal kyphosis, usually in thoracic spine, when it is more than 40 or 45 degrees. Nowadays, you can hear kyphosis as when a deformity surgeon told you I have a kid with a kyphosis, that means abnormal kyphosis, not the normal sagittal alignment. Now, there are many types of spine deformities. I found the best to classify it according to the age of presentation. So if we look here at this table, we can divide the patients below 18 years and above 18 years. And we have the early onset, which is below age of 10. So usually below 18 years, deformities are congenital scoliosis, neuromuscular scoliosis, idiopathic scoliosis, which is the most common type in this age group, shared kyphosis, cellulitis, spondylolisthesis in the kids. This is part also of the deformity. Above 18 years, we have also the idiopathic, which is shared from the below 18 years, but the degenerative or de novo, which is the most common type, and also the spondylolisthesis. But in this presentation, we will not talk about spondylolisthesis because most of you may be aware of this kind of deformity. So we'll talk about the other types. Always also look at this at the slide. We have what is called early onset scoliosis. Early onset scoliosis is any deformity below the age of 10. Either it is congenital, neuromuscular, idiopathic. This is always early onset. It's important because very difficult to manage. We still have a kid who is still growing. We cannot fuse kids at this age. It has a high complication rate, like a crankshaft phenomena. You all are aware of it. Crankshaft phenomena is a nightmare of deformity surgeon in early onset scoliosis. The management options for early onset, it goes from conservative like observation and bracing, growing rods, including magic rods, and limited air fusion with or without corpectomy. And nowadays we are doing posterior and sometimes anterior tethering for these cases. First type, which is the congenital scoliosis. It is usually two main types. We call it type 1 deformity or failure of formation, which is the hemivertebra. It is a wedged vertebra, which is just formed from one side. If you look at the X-ray, we have an example in the next slide. You can see just only a pedicle at one side. Failure of segmentation, which is type 2, where is a bar. This bar prevents the spine from growth where it is catch the spine. So in hemivertebra and in bar, these are the congenital scoliosis. You can diagnose it mainly by a 3D CT scan, but most of the time you always you can catch it. We still don't know the incidence in the papers, and it is more common in gears 3 to 2. What is important in congenital scoliosis is to look for another associated anomalies. Up to 60% of congenital scoliosis have another anomaly. The most common are spinal cord and genitourinary tract. These are the most common, and cardiac. So spinal cord, genitourinary tract, and cardiac malformation are very, very common association with congenital scoliosis. So once you diagnose a patient with congenital scoliosis, which means if you find a bar or you find a hemivertebra, you have to screen your patient. Remember the VACTRL association, which is vertebral anomaly, anal atresia, cardiac, tracheoesophageal fistula, renal, and limb association. Klippel-Feil syndrome also is very famous in our area, which is cervical fusion. It is another differential for torticollis. It is usually limited neck range of motion with short neck and low hairline. These are the examples of two types. If you can look here at the mouse, you can see just only half a vertebra. This is L4 hemivertebra. If you look here, you can find another hemivertebra at L1. If you maybe look more, you can find another hemivertebra here at T11. So when you're looking at the X-ray for the scoliosis, you have to look at the two pedicles. Two pedicles you have to see the two pedicles. When you have just one pedicle, most probably this is hemivertebra or failure of formation. Why that makes the scoliosis? Because the growth rate at the side of the hemivertebra will be much faster than the other side. The other example, which is failure of segmentation, I have to go with the mouse just to let you see the huge bar here from T11 up to T5. This bar prevents the growth of the spine anteriorly, and the growth comes from the back. And this is what's called the failure of segmentation or bar. These are the two congenital scoliosis that you have to look for. Now we will move for the neuromuscular scoliosis, which is a large curve. In this presentation, I will not go for detailed of management, because I think we will talk later on in future presentation about the management of each one by one. So the second part of our deformity is the neuromuscular scoliosis. It is usually large, curves early in life, usually stiff and sometimes very flexible and osteoporotic spine and bone. Usually progressive curves. It is a C shape. This is characteristic for neuromuscular type. When you see a C-shaped deformity, think of something abnormal in the muscles or in the nerves. Usually these patients are poor, they have a pelvic obliquity, they have sagittal plane deformity, they cannot sit, sometimes they cannot walk. So I think this is very bad deformities. I always would like to refer them to Dr. Firas to deal with them. Classification of neuromuscular, we have two main types, the neurologic and the muscular. Examples of neurologic like cerebral palsy, myelomeningocele, spinal muscular atrophy. Any muscular atrophy lead to muscular type of neuromuscular scoliosis. The idea of these deformities that the imbalance of the power of the muscles. We have imbalance of the power, and usually the strongest muscle will always bring the spine toward its side. So the management, we have to do a general and a local. General means to manage all the other problems of the patient, and locally. This is one of my patients. On the right side, you can see how bad thoracic lordosis he have, and how bad kyphotic area with very bad. I think he came to me because he have very bad ulcer at the back. When he sit down, he cannot sit down. So usually the management depends on the disease and on the care. Idiopathic scoliosis, fortunately, this is the most common deformity. Most of the deformity guys would like to deal with this type of deformity. It's the most common. And the care should be more, the etiology, that's why it's idiopathic. Although we know it runs in the families, I have I have a families, the mother had scoliosis before, and 2 or 3 of her kids came to me for surgeries, so it runs in the family. So once we have a patient with idiopathic scoliosis, we have to screen all the families. We have a genetic factors, as we said, CHD2 and CHD7 genes may be related to this, but till now, we couldn't prevent that. Types, that, you know, the types, we can classify it according to the age. So if we diagnose the patient below 3 years, it is, we call it infantile, 3 to 10 juvenile. And infantile, juvenile, this is part of the early onset scoliosis. Fortunately, adolescent or AIS, Dr. Firas will talk about this in the second presentation. This is the vast majority of deformity in this age group between 10 and 18. Adult deformity above 18 years old. What is the natural history of idiopathic scoliosis? 90% of infantile curves show spontaneous resolution. 70% of juvenile curve progress. What are the important factors to prognosis to tell your patient that you have you will have a high likely progression rate? Growth potential. If we have still a kid with a growth potential, this is a bad sign. Skeletal immaturity. We look at the riser sign. If skeletal immaturity is a bad sign also. Curve magnitude, when we have a big curve that progresses much more rapid than small curves. Curve location, that means thoracic curve progresses less rapidly than curve always progress very, very rapidly compared to thoracic. And we have the rib vertebral angle difference. I had a slide, just remove it because I think it will be complicated to talk about. It's just an angle that give an idea, it's not an obsolete, give an idea that the curve will progress or not. This is the riser sign on the X-ray, pelvis X-ray. You can see the iliac apophysis appears to be on line 3. So if you look from lateral to medial on the X-ray, if the apophysis in the first square, this is 1 or 2. 1 or 2 gives you an idea that it's skeletal immature. The kid is skeletally immature. 3, 4, and 5 usually started to be matured. 5 almost matured. So the bad one is 1 and 2. Logistic vertebra, just to make life of Dr. Firas much easier, just to mention the apical vertebra. Apical vertebra, which is at the apex of the curve. This is the apical vertebra. Usually this is the most rotated vertebra and the least tilted vertebra. It is on the apex. We have the end vertebra. We have the upper and lower vertebra. These are the mostly tilted. And you can measure the curve between the upper and lower end vertebrae. And this is what we mean by Cobb angle. Stable vertebra is a vertebra that dissected by central vertical line. Just to mention classification, linking classification for AIS. This is just only for AIS. Dr. Firas will go in details of for this classification. It contains of 3 major types: the curve type, and the modifier, A, B, and C, and the thoracic profile. He looks here also at T5 to T12 sagittal profile. If it is below 10 degree kyphotic angle, this is hypokyphotic or minus. The N is normal between 10 and 40, above 40. The modifier, this is for the lumbar spine between L1 and L5. You can see this line. You can see this is a central sacral vertical line. If this line come between the pedicle, this is A. If this line come and touches the pedicle at the apex, this is B. If it is away from the apex of the curve, this is C. This gives you an idea where to stop your anchors distally. This is an example of AIS, this 14-year-old. This is my first case when I get back from my training. I just added because this is my first case in Jordan, and this is after fusion T3 to L2. Now we will move to another important part, which is pediatric kyphosis or Sherman disease. Kyphosis here mean abnormal, because you know the lordotic curves are compensatory. When we are infants at day 0, our spine is C-shaped. When the infant starts to elevate his head, he will have a lumbar, we start to have a cervical lordosis. And when he starts to walk and elevate his back, he will have the lumbar. So that's why it's a lordotic curve are compensatory. We are usually would like to go for kyphosis. And you know, when we became more than 60 or 70, going down the age, we also start to go back to the lordotic, to the kyphotic position. So normally from T2 to T12, the kyphotic angle should be between 20 or 45 degrees. And the lordosis from L1 to S1 depends on the pelvic incidence, should be usually between 40 and 75. But anything above 45 degrees in the thoracic spine, this is abnormal. I didn't mean that after 45 we have to operate, because still we wait until higher angles. So Sherman disease, very common. It's describing in 1921. It's very old diagnosed. Most common cause of severe thoracic kyphosis in adolescents. The other, in the past, we used to see ankylosing spondylitis in the adults, and this is another major cause of kyphotic angle deformity. But fortunately, now the good rheumatological patients, the number of patients is going relatively very low. Prevalence of Sherman disease between 1 and 8. This is the only deformity where boys equal to girls. 33% associated with scoliosis. And these usually very, very minimal angles regarding scoliosis, about 15 to 20, not more than that. Most of the problem in the sagittal plane, which is the kyphosis. And usually diagnosed at the age of 10 to 12, and sometimes associated with spondylolysis at L5S1. These are the radiographic criteria for Sherman disease. As you can see, we have two. One of them is the two should be there to diagnose Sherman. The first one was vertebral wedging gland 5 degrees in 3 consecutive vertebrae at the apex. So we have a vertebral wedging in 3 consecutive vertebrae. Other criteria which is associated with indibulate irregularities and Schmor's nodes. Now I'll move to adult scoliosis. We have 2 types, idiopathic and degenerative. We know that at this age group, which is above 18, the degenerative is the most common, and that one we will talk about. When we are talking about degenerative scoliosis, we have to pay attention to the sagittal plane. That's why it's very important to measure always the pelvic incidence and the lumbar lordosis in these patients. So pelvic incidence is the angle between a perpendicular line to mid-sacral area and the line from the same to the mid-femoral head. So if you draw a line, this is the femoral head, center of the femoral head to the mid-sacral point, and this is a perpendicular line, and this is the pelvic incidence. This is very important to us because lumbar lordosis, when you fusing the spine up to the sacrum, you have to predict what the lumbar lordosis of the patient. Pelvic incidence is different between the plumb line. This is very important also. Normally, a line from C7 downwards is usually within 2 centimeters anterior or posterior from S2, should bisect the femoral heads and continue down through the malleoli of the ankles. This is the sagittal vertical axis in degenerative spine where the patients usually go forward. So this is the distance between S1 and the plumb line. This is SVA. I just put it because it's important in the Schwab classification. So Schwab classification, like Linke for AIS, Schwab for degenerative. It contains of 4 main types: coronal curve type, either it's thoracic, thoracolumbar or lumbar, double curve, or if there is no major coronal deformity, it is still scoliosis, the main problem in the sagittal plane. So it depends if pelvic incidence minus lumbar lordosis about 10, this is the normal 0. If the pelvic incidence below lower lordosis more than 10 to 20 degrees, it is moderate, and very bad or marked if it is more than 20 degrees. And most of the surgeries indicate plus to go for surgery, even for the global alignment and SVA that we just talked about. SVA, if it is less than 4 centimeters, we can still call it normal. But if it is 4 to 9, this is plus more than 9.5. And also he looked at the pelvic tilt as a compensatory mechanism. The prevalence is approximately 6%. Average age at the presentation is 6th and 7th decades. The care progression is 3.3 degree per year. Usually females more than males. Symptoms different from the pediatric age group. Usually these patients presented with pain. They have neurogenic claudication, radicular symptoms, and back pain. An example of degenerative scoliosis. You can see the degenerative changes at the apex of the curve. You can see also the lateral listhesis of lateral listhesis cause root traction, cause severe radicular pain, and you can see the obliquity of the end plates. What the indications? As we said, we will have a complete talk about this type of scoliosis later on, but As a general rule, usually the indication for surgery depends on the pain that unresponsive to non-operative care, functional limitation, progression of deformity, and neural impairment. Last thing that I would like to talk about, which is spondylolysis. It is a defect in pars anticularis, most common cause of back pain in adolescents, and may lead to spondylolisthesis. You can see on the oblique X-ray, you can see the Scotty dog on the oblique X-ray, and defect on the neck of the dog is the spondylolysis. It is usually associated with spondylolisthesis, or sometimes came without spondylolisthesis, but it is really a common cause of back pain in adolescents. We come back to our case, this 7-year-old kid. If we went through the history, usually the history of scoliosis is not that big, because we also what we ask how you pay attention to the deformity. If you have a previous X-rays for the chest for any reason, how if you treat before, did you start on a brace or so. This kid presented with the progressive deformity since the year of 2. He was diagnosed incidentally as a chest X-ray. The angle was 10 degrees at that age, and he had an X-ray every 2 years, but he missed the X-rays. This is just only from the history, and he came with this angle 50 and 40. So options. So Dr. Saad, can the audience?
Yes, if you can answer, you can raise your hand, and we'll see who will answer.
So we have, I think this is the management options. So we have exercise and follow up until puberty to do a fusion. Anyone with this?
If you are with number 1, raise your hand. One, only one. 2.
What about bracing and follow up?
3. We have 3. Actually 4.
Conventional growing rods.
1. Only 1.
What about magic rods? Do you know the magic rod? It's a growing rod that you lengthen the rod without surgery.
2.
2.
3.
Okay. 3. Posterior tethering. Anyone aware of this technique?
2. No.
Anyone have other option?
Dr. Sami? Dr. Sami? Samer? Dr. Samer Sami?
Yes. Hi. Good evening.
Good evening.
Yeah. What about anterior tethering? Is another option also, if it's available.
You prefer to do it, or just you as an option?
It is an option, actually.
Yeah. Still not FDA approved, but it's one of the options.
Yes, exactly.
Okay, so what we did, so growing rod, you can follow up.
Yeah. Dr. Hassan?
Yeah, I will go for anterior tethering. I agree with Dr. Sami, because I believe we can use a new technique, applying the screws and flexible rod, which allows the correction of the coronal and sagittal profile. Because growing rod or magic rod, you can correct the coronal plane, but the sagittal profile will be passively affected. That's the disadvantage. I will reserve growing rod or magic rod for congenital scoliosis with severe degrees of deformity.
So you still use a magic and growing rod. The problem with the magic and growing rod that didn't control the rotation, and usually they always with distraction we have a hypokyphosis with the curve. I agree with
Yes, that's what I mean.
these are the
would-
problem. Yeah, these
yes.
are the problem with the growing and magic rod, but still they are valid till now.
Yeah.
And it's very expensive actually also.
The magic rod, yeah, is very expensive. Yeah, I know. And the
It-
anterior
it-
tethering is much. I think the anterior tethering is not cheap. Anterior tethering is very, very expensive also. So it's
But
an
it
options.
is not that expensive like
As
the magic rod.
exactly.
Yeah, magic rod will cost in Germany 2 rods about 30,000 euros, but you still have the option of anterior tethering with the screw and rod system, which is it's expensive, but it's not that expensive.
How much it cost the anterior tethering?
Oh, I will say about 8,000 euros, but for the construct about 8 screws or something like this. But you need the technique. You need to be aware of thoracoscopy technique, because we don't like to do open thoracotomy in such kids. I still say it is theoretically better, but the experience of thoracoscopy and anterior surgery is a must, because you have to be a very good anterior surgeon to be able to do it.
I know. This is a new technique. I think in the future it will be a great technique with the experience of anterior tethering. But I think it is much more expensive than 8,000 euro. I don't think it's just only 8,000 euro.
Firas has a comment, I think.
Yes. With regards in the early onset scoliosis, I see all the options. I see as many of our colleagues, they are still using growing rods conventional, and others they are still using magic rods. But the tethering in general as a technique is a new technique in the last few years. We are talking about the last 5 to 10 years, and there is really very good results regarding the anterior and posterior, both of them. But still, we need more data and evidence to see what is the best. I believe that posterior tethering is really inexpensive. You can use any screws and connections in your clinic. This anterior, it's really expensive. Even it depends in the country where it is exactly and who can give you this. But I agree also with my colleague, Dr. from Germany, Dr. Sami, and that the most expensive of these techniques is the magic rods. And there is also the peptide surgery that we don't use too much nowadays, but I started this in 2008, and I have a lot of patients, but we have a lot of even follow-up complication with it. So I believe that in the future, that either posterior or anterior, both of them as it's a techniques of real techniques of scoliosis surgery in general, early onset and even in juvenile scoliosis.
Yes. So when the magic rod started in the USA, most of the surgeons started to use it. In the States at that stage before the corona, the cost is not an issue. So they started to implant a lot of magic rods and started to have major problems with broken screws and the hypokyphosis. And nowadays they started to stop it, not because of the cost, but because of the complications. Now what we did is this is a posterior tethering. We started this technique with Dr. Ala Azmi in Abdari Hospital. In the last 6 months, we did around 8 cases. It depends on the posterior tethering. This is a fusionless surgery. The only segment that if you use it is the base. So this is the screws where we do a fusion here. Then we look at the apex, which is at this curve. If we say this is 12, 11, 10, I think this is 9. So we put a screw above and below the wedged vertebra at the apex, just to control the rotation and to control the growth without any fusion. And we put hooks on the clavicle just to control it. So after the surgery, we usually 50% of the deformity will improve. And if you look here at the dominoes, we keep this is open just to let the kid start to growth and elongate without surgery. So to us, this is cheap, and you can control the rotation. You can control the kyphosis. So this is the pre and post-op. So we started this technique in Jordan maybe 6 months. Until now, we have no problems. Dr. Ala have experience with that maybe more than 4 years, and you have a very good results. And I think we will let you know how the issue is going.
Great.
Excellent case. And I believe I saw also anterior tethering by Dr. Aydogan from Turkey, and I saw even nice results with him, and there is more flexibility with the patient because it's a flexible routes from anterior than the posterior.
It's a fusion, yeah, it's a fusionless. Yeah.
All these techniques are non-fusion, but I saw a very good result also by Dr. Ala Azmi from Palestine, and he has a follow-up of more than 4 years, and he has promising data and promising results.
So
I'd like to add a comment or a question.
yeah,
For our younger colleagues who are listening to us, I believe the speaker should explain to them why do we have to operate in such a young patient? Why is waiting and observation is not an option in such a patient? Because we suffer from those patients who got this follow-up for years and years and come to us with a 80 degrees thoracic rigid kyphosis. Our duty is much difficult when we wait. So I'd like to hear your comment.
I agree with you, but still there is a room for bracing. Some surgeon, even in the States and deformity surgeon, at 50 degree may be waiting until it reaches 60 degrees. So I think 60, the cutoff, 50 with immature, he will need a surgery anyway. So I think to treat a patient with the 50 and 40 degrees at this stage, it's much better than to wait until the curve become 100 or 120 when he's become at puberty age. But if you want to wait 6 months and see if it's become more, maybe 60, you can operate at that time. But to me, 50 degrees is a cutoff to go for a surgery, because this is a progressive 50. It's a huge curve at this age, immature patient. So I think this is the indication for the surgery.
Good
Yes,
evening, Dr. Hassan Salhin and all
hello.
friends. I'm Samer Sami from Alexandria, Egypt. I'm with my RD presenter about we can wait with the brace and physiotherapy and some training to if it is 50 at 10 years old, we can wait for about 6 months. The kid might not progress that much. For sure, we will not wait for 80, and we have to do close observation. But I'll go for the Boston brace or any other type of brace available in each country that might afford us a time to go for a permanent surgery once and forever.
Yes, I agree also with you. If the kid was 10 years old, but we have a kid who is 7 years old with a degree of 50 degrees. Yes, and if you wait, you can end your fusion or your surgery here at the thoracolumbar junction. But if you wait and wait, the lumbar curve is going to be structural, and you will lose other 2 or 3 segments. You have to go to L4. But if the kid is 10 degrees, I agree with you, absolutely. I will wait until he is 12 or 14, maybe, according to the progression of the curve. It is not the discussion I need.
Exactly.
Thank you. Okay. Thank you, Dr. Samer.
Thank you.
Yeah, but just, the last comment, just I would to talk about why 7 years you do non-fusion techniques and why you start at this magnitude of curve. There is 2 reasons. You know that, in 1972, Texon, he did his classification of scoliosis as early onset scoliosis. And the meaning of early onset scoliosis, the main concern is the respiratory system. So it is the number of alveoli is safe at the 5 years old in comparing to the adult, and is it reaches the maximum number as adult life at the age of 8 years. So we have the first of all to have a thoracic cavity for the lungs, and the second, as my colleague said, that if deteriorate by the time, you have to go to the lumbar, which is structural, and you have to do your fixation down, and you will not preserve any motion in the lumbar spine, which is very important for the quality of the life for the human being. So I believe at this age, if you start to do non-fusion technique for correction to the adolescent age that you can do permanent, it's one of the accepted ideas.
Muhammad, how's your lecture? Is it finished yet?
I think we finished, yeah. Just to
there's a question from Dr. Massimo. Why did you stop at the apex of the lumbar curve?
So I don't have the bending X-rays here. I think the apex is at L4. I would always think about it if we go much more down than this. In this kid, I think this is not a structural curve. So I believe I can stop at this and it will be corrected when the thoracic curve will be corrected, because it's not structural. If structural, definitely I will not stop at the apex.
Okay. So, Dr. Firas, can we start your presentation, please?
Yes, please.
Dr. Firas is he's the chairperson of the Jordan Spine Society. He's a well-known spine orthopedic surgeon, and he is going to talk about idiopathic adulthood idiopathic scoliosis approach. Please, Dr. Firas.
Yes, just 1 minute because I'm preparing. Sorry.
Mm-hmm.
Okay. So I will do. Can I do my share? Dr. Mohammed, you have to go out with your lecture because I want to share my screen. I cannot share my screen unless you are out.
Yes.
Okay. Is it okay?
Yes.
Excellent. Can I see? This is okay. Okay. This is my short CV. Our talk today is about the management of adolescent idiopathic scoliosis. This lecture today, it was, planned for our society and AO Spine in Jordan, but I'm amazed and I'm very happy to see other visitors from international. The topic, the objectives of this lecture today is about to answer these questions. The first two questions: what is scoliosis and deformity in general, and why do we treat scoliosis, covered nicely by the comprehensive lecture of Dr. Mohammed Armouti. I would like to thank him. And I will answer the other two questions about when do we treat idiopathic, adolescent idiopathic scoliosis, and how do we treat it. So why we just talking about adolescent idiopathic scoliosis, as said Dr. Mohammed, that is the most common type of scoliosis, about 80% of the types. That's why we are talking about adolescent idiopathic scoliosis. So in my start, I think that medicine is the art of a probability. So there is nothing 100% sure. We have to know the physiology, the pathology, the anatomy, and then to analyze the personality of the disease for its diagnosis and treatment. Martin Fisher said, scoliosis is an ancient disease that's incompletely understood, despite a collective medical experience that approaches 4,000 years. And really, my colleagues, this is a sad, very sad commentary for the learning curve of the medical practitioner. Even though the history and the recognition of the treatment of scoliosis is rich with very important lessons for the modern practitioner. So we are talking about a clinical algorithm, and I have seen, this is that I do in my clinic every day, and I applied it, and I from one of my colleagues that we if we take care of these steps step by step, we can reach to acceptable really decision of the treatment. So the unique of scoliosis that we are treating X-ray, since there is no serious symptoms that we have to take care of the source of it. So we are seeing the X-ray, and we went to fix this spine in the original curves, taking care of the normal curves and the weight distribution over this spine, and to remain functional and not as a stack. So the first step, just we make the diagnosis. The second step, we assess the risk of a progression, and there are many ways how to assess the progression of the care, but we will just use two types of it. And then we determine the need of a treatment. If the patient that we need observation or we need something more than this. And after that, we choose the type of the treatment, which is usually conservative or bracing or surgery. So if anyone see this, slides, it's a very busy table or very busy algorithm. But if we analyze it, it's very easy to understand. It just tell you how to do the diagnosis of scoliosis. The first one is, what is the Cobb angle that already Dr. Mohammed talked about it. So if the Cobb angle less than 10 degrees, so it's not adolescent idiopathic scoliosis, and sometimes we name it scoliosis. And the meaning of this, that it's a benign, non-structural care that needs observation and some physiotherapy. And if this care progresses, then we go back to adolescent scoliosis. The other one is the age, which is very important. If the age is above 18 years old, so it's adult scoliosis. And as Dr. Mohammed said, there are many other parameters to account in the treatment of adult scoliosis. But mostly, if it is below 30 or 25 degrees, it's the same treatment. Above 30, there is degenerative signs, so we have to look about the sagittal balance and to do reconstruction and to treat the source of pain that the patient has. If it is below 10 degrees, it's infant juvenile scoliosis, and it's not, and the juvenile scoliosis, most of the cases, we can treat it exactly as adolescent idiopathic scoliosis. But some of these cases, we go to the early onset scoliosis, as the last case of Dr. Mohammed, that it needs non-fusion techniques because of the impact over the body and the respiratory system. So if it is the case 10 to 18 degrees, yes, it is adolescent idiopathic scoliosis. We go to the parameters to see if it is a typical adolescent idiopathic scoliosis or not. So typical idiopathic scoliosis, so it is, as we know from our basic information, that should be female, right thoracic curve or left thoracolumbar, and the curve, there is no acute angulation, and the curve should be typical as proximal thoracic, main thoracic, thoracolumbar or lumbar. And this is the typical. So if we have, as example, left thoracic curve and right thoracolumbar is not typical. So we have to go to do MRI and work up to see if there is something else. If there is nothing in the spinal column or the spinal cord, so we go back, it is idiopathic scoliosis. Boys, not all the boys we need MRI, but females is about 90% of the cases. So usually we advise even in males, we go to MRI for more further investigation. So if it is normal, it is idiopathic scoliosis. Then we have the angular or atypical curves, which indicating that there is something disease associated, or there is abnormality in the spinal cord or the spinal column. So we have to do further investigation. If not, it's idiopathic scoliosis. Then we examine for syndromatic features like Marfan's as example. And we examine the same. Sometimes we have like Marfan's syndrome, but it's not Marfan's, so we can exclude this. So if it is Marfan's, so it's a syndromatic, it's completely different treatment. And we have to take care of other parameters. But if not, it's idiopathic scoliosis. At the end, in the examination that we need our basic, if we see as example hairy patch lesion, so we have to think about the stomatomelia. If we had dumbbells over there, so we have to think about the neural defect and the neuromuscular scoliosis. If not, in the further investigation, it's idiopathic scoliosis. So this is the diagnosis. So this is adolescent typical idiopathic scoliosis. After the diagnosis, we go to the how to assess the progression. Here, really, it's the intersection between the potential of the growth and the size of the curve. So these curves usually tend to progress according to the potential of the growth of the child. So the highest risk of curve magnitude is going in the adolescent growth spur. These data that we have in this slide. This is from the study of Lowenstein. This is Lowenstein. This is in 1984, and he studied different factors to differentiate between low, moderate, and high risk progression. So if you see that the main two factors that I do in this slide, that the Cobb angle and the maturity. So if the Cobb angle is low, if the Cobb angle, we are talking about low, and maturity is mature, the patient is the risk is low. But if the Cobb angle is low and the maturity is low, is high, and the maturity is low, if the Cobb angle is low and the maturity is the patient is immature, is a moderate risk. And if the Cobb angle is high and mature, is a moderate risk. The only high risk when we have very high Cobb angle and immature patient. And then we put the patient, how is the risk of the patient? And this is playing a major role in the follow-up and in the type and the aggressiveness of the treatment of the scoliosis. And this is the paper of Lowenstein. Then we can differentiate now, determine the treatment. It is non-operative or operative. In general, we are talking about this. So any Cobb below 35 degrees, we have to do non-operative treatment. And skeletally immature patient and the acceptable clinical appearance. These cases usually immature or immature below 35 degrees, it is non-operative. When we think about operative, it is Cobb angle over 40 degrees, a skeletally immature patient. And if it is even 40 degrees with less than 40 degrees and skeletally mature with unacceptable clinical appearance, we think about surgery. So what's the operative, what is the types of a treatment? The non-operative treatment, it is the physiotherapy, and there is no any evidence study till now that can correct the deformity, but it can, strengthen the muscle, it can treat the pain, and there is also evidence studies that can affect in the kyphosis, may affect in the kyphosis deformity, kyphotic deformity. The observation, any case with less than 25 degrees, we do observation. And when we are talking about observation, we are taking care about, how to do some exercises for the patient to strengthen the muscle and to do the follow-up with us. And the bracing, if the curves above from 25 to 40 degrees, even will stabilize and not correct the deformity. There is a lot of studies in the literature, but there is no evidence study that really bracing can correct the deformity, and it's only for immature patient, and it's only for less than 40 degrees. And surgery, as we see in our indication, that any case more than 40 degrees, we have to plan for surgery. And this is our lecture today, how to plan for surgery. Two very important points when we are thinking about surgery for scoliosis. The first point, to determine which curves to instrument and diffuse. And so which curve? This curve, we have, very big curves. We have compensatory curve, which is small. So I have to do all of it, or I have to be selected to do which curve. And this is very important, point. And the second important point is where is the fuse? So where to start and where to end? Because if you don't do the good starting point and the end point, the instrumented vertebra, you will have also adding in foramina. So we will have again deformity and scoliosis. So in our evaluation, as you see, we take the proper X-rays, and the proper X-rays is upright AB and upright lateral, or starting from up the shoulders till the pelvis down, and the bending X-ray, which is very important to show the flexibility of the curves. There is many ways to see the bending of the curves, and it depends on the surgeon and his experience, what he use as supine bending, or fulcrum also, and so, or tractional flexibility by traction X-ray. It depends on the surgeon and his technique. After that, I would like to explain again that Muhammad talked about how to see the curve. So the most displaced vertebra or disc space to the horizontal segment is the apex. So it could be vertebra or disc space. And this is important to see, and this is the apex where it is, and to go. If it's right, so it's right thoracic scoliosis, it's left, or left thoracic scoliosis, and so on. The other point is to see the end vertebra. So we have two vertebra, which is the upper one, which is the most tilted vertebra toward the concavity of the curve, and the end plate, the superior end plate, and the inferior end plate of the lower vertebra, which mostly tilted to the concavity of the curve. And this is the end vertebra. And from this end vertebra, we can see what is the cup angle, and we can measure the cup angle. The other important sign, which is the neutral vertebra. The neutral vertebra is the non-rotated. So if you see in this X-ray, you see this is rotated toward the left, this is rotated toward the right, and this is the neutral between them. And this is the neutral vertebra, which is the pedicle asymmetry, which is important vertebra in our planning for surgery. And the last one is the stable vertebra, and this is the vertebra that bisected by the cervical or central sacral vertical line, which is in this case the L4 vertebra. And this is the stable vertebra in all cases. If you start your reconstruction from this, you are safe. But you can go to the neutral or the end vertebra according to the care to serve more vertebra for emotional preservation. And how would these, data that we talk now, we are talking about clinical classification, how we can clinical classification help us to guide you in which care or the selection of the curves for fusion. And the classifications in general is very important, regardless that it is a common language between the surgeon, but some classification like Linke, it can guide you to the decision where to fuse exactly. Regardless, there is some question about the criteria, and there is some studies about the criteria to be 100% or 80% in the planning of the surgery. So this is also very busy, as you see, table. But if we just discuss with you about it and you have it all the time in your hand, it's very easy to use it. Well, first of all, we are talking about the location of the apex. So the spinal column is divided to 3 major areas, and the thoracic curve from T2 to the disc space of T11, T12. But even the thoracic, we divide it in the proximal thoracic and the main thoracic. The proximal thoracic is from T2 to T5, and the main thoracic from T5 to T12. And then we have the thoracolumbar from T12 to L1, and we have the lumbar, which is from the disc space from L1 to L2 to the L4. And from these points, you see, this is the apex we see, sorry, the apex where it is exactly in these cases. The proximal thoracic, the apex is usually T2 and so. So we know in the location of the apex from the curves itself. So the and the second, the thoracolumbar from T12 to L1, and the lumbar from the disc space of L1, L2 to L4. And then we go to the structural criteria, which is the second part. And from these criteria, you see the proximal thoracic, the main thoracic, the thoracolumbar and lumbar, and if any side bendings more than 25 degrees is structural. Less than this is really non-structural. The thoracolumbar and lumbar is the same, and the main thoracic the same about the side bending. There is in the sagittal plane, the kyphosis from T1 to T5, if it is more than 20 degrees, and from T10 to L1, and from T10 to L1, the same kyphosis. If it's more than 10 degrees, it's also structural. The main criteria is the side bending. And about the kyphosis is the same, but there is some studies talking about the availability of the minor structural curves in the Linke classification. So after the two steps that I know where is the apex and I know what is the structural criteria, I can classify it as a language. As example, the main thoracic, the meaning of this that the main thoracic only is, structural, but the other curves, the lumbar, thoracolumbar, and the proximal thoracic are minor, and we don't want to fuse it. So in the main thoracic, we fuse only the thoracic. In the type 2, which is the double thoracic, we fuse all the thoracic, the proximal and the main thoracic. The type 3, which is the double major, in this the main thoracic and the thoracolumbar lumbar, we fuse both and we leave the proximal thoracic. In the 4th type, we have triple. So we have the proximal thoracic, main thoracic, and thoracolumbar lumbar are structural. So we do all of them fusion. Type 5, which is the only thoracolumbar we fuse, and type 6, we fuse the lumbar spine with the thoracolumbar. So this is the guidance for which curve that we can do fusion. We have other 2 modifiers, which is the lumbar spine modifiers, and it depends, as Dr. Muhammad explained also, in the central sacral vertical line. If it is between the pedicles A, if it is in the pedicle, in the concave side, so it's B, it's beyond the pedicle, so it's C, and it's playing role about the flexible curve also, how much you can correct it or not. And the thoracic sagittal profile, it's a very simple. If it is between T5 to T12, if it is less than 10 degrees, so it's a neutral, so it's minus. If it is between 10 to 40 degrees, it's a neutral. It's above 40 degrees is positive. So I explained really the 5 types or the 5 sections of classification of Linke, to go then to selection of the curve, and to go to see over the patient what we are doing in the X-ray. So in the Linke classification, the major and structural minor curves are included in the construct. The non-structural minor curves are excluded from the construct. And in this classification, we have to determine, it does help determine which curve included that we talk about, and it does help determine the distal. It doesn't help determine the distal and the proximal levels or the instrumented vertebra. So in this case, as we see, we have the main thoracic is at 56 degrees, which is the major one. As you see, the lumbar is 15, and I have to see where is, sorry. And the proximal thoracic above is about 18 degrees. If you see, sorry. So this is the lower end vertebra, this is the neutral vertebra, and this is the stable vertebra, and the T9 is the apex of the curve. So in this case, as you see, that in this case, what we do, we have to select the lower instrumented vertebra and the upper instrumented vertebra. Here, the surgeons really have a lot of discussion. But if you see that, you know, the neutral vertebra is the L2 and the end vertebra is the L1. And this depends on the flexibility of the curve to select what is L1, L2. Some surgeons, they will go to L2, some surgeons, they will go to L1, and we will see where we did our fusion. And the proximal vertebra, usually, it is one, it is the one vertebra over the end vertebra of the curve. So the flexibility, as you see, it's very flexible about the lumbar. It's about 0, and about the thoracolumbar is 11 degrees, which is minor. So the selection, we are going to do selection of the main thoracic curve. And about the lower instrumented vertebra, if you agree with me, is L1 is the vertebra that we instrumented. So in the other, we will see in the next slides. The other one is the thoracic curve, which is 38 degrees, which is a neutral between 20 to 40 degrees. After we determine every issue, why we use as example in that case, some of the surgeons, they will go to L1, and some of the surgeons, they go to L2. It is here the balance. So if you want to preserve motion, you go to the L1. But if you are in concern about to have adding on foramina or to avoid progression in the future, you go to L2. So you have to balance between preservation of motion and avoidance of adding on foramina. The meaning of this, the preservation of motion, the selection of a fusion, and avoid, you do more vertebra or more curves to avoid the progression, and you do less vertebra to have preservation of motion segment. So you have to go between them, and this is the problem of scoliosis, that it doesn't have cornerstone or standards to see where is the distal and the proximal. It needs to study many cases and to have lessons from other colleagues to know exactly where is the target and the point. So to know the upper instrumented vertebra, we will have general rules. First of all, you have to assess the proximal thoracic curve, its structure or non-structural. The other very important as the question of many of the colleagues, that to see the sagittal plane and to see where is the kyphosis. If there is proximal thoracic kyphosis, you cannot stop in the apex, you have to go up. And where is the also shoulder tilting, if it is in the right and in the left, and you can estimate exactly where is the upper instrumented vertebra. The lower instrumented vertebra is also it's the lower vertebra that you start your instrumentation. It could be, as we talk, it's the end vertebra, it could be the neutral vertebra and the stable vertebra. Usually, if it is the end vertebra and the neutral vertebra is the same vertebra, this is very successful vertebra to start. But if it is the neutral vertebra, one vertebra over the stable vertebra also is excellent. but to start. But if it's the end vertebra is 2 vertebra above the stable vertebra, so you have adding phenomena about more than 25%. So here you know where to start the end vertebra. Usually the rotated vertebra, if it is 1 vertebra above the stable, or it is with the end vertebra, is the most successful vertebra to start your instrumentation as lower instrumented vertebra. You have to remember every time that the junctional kyphosis and the spondylolisthesis in consideration if you plan for the lower instrumented vertebra. This is the case. We will put some cases, according to the link classification. So it is a 15 years for a female patient. Reiser 3, the meaning of this, that 75% of maturity is reached. So it's a mature patient. This is the case that we just talked about, and the apex is T9. We explained that it's a flexible curve, and we start our the lower instrumented vertebra, it was L1, and the upper it was T5. And this is a straightforward, simple case. The other case is this case. It is a 14 years old female patient. It is also Reiser sign is 3. It's a mature patient. And if you see the curves that you see, the main thoracic is 94, which is the major, the biggest one. And we have other 2 curves. 42 is the second major, and we have a minor is 25%. So 25 degrees, sorry. So we see the shoulder tilt, and we see where is the stable vertebra, which is about L3. In this case, we see also we have plus, which is 65 degrees of kyphosis, and the modifier of the lumbar is B between the pedicles, which is excellent to go to have a very steady lumbar in curve, steady lumbar spine in your fusion. So the flexibility, as you see, we have 2, the major curve is already defined, and the minor curve is 25 degrees, which is still the proximal curve is rigid. So in this case, we have the type 2, which is the double thoracic curve. So we go for fusion of the thoracic, main thoracic and proximal thoracic, and we did this fusion and this fusion. This surgery done by in 2008, and I did anterior, and at that time I did a lot of anterior surgery in these cases because it's a very severe case, and this is the end result of the same patient at that time. The third case is we have 3 types, which is the proximal 21 and the main thoracic 68, and the thoracolumbar is 46. We see the apex is T8 and L1, and this is the double major. So the flexibility, as you see, the main thoracic lumbar curve is 40 degrees, and the main thoracic is also the major is 42 degrees, and the proximal is 19 degrees, which is in the case non-structural. So we do fusion for the double major, and this is the end result, and we see corrected also the kyphosis to neutral is about 32 degrees. Other case, this is the case which is one of the cases that severe is 107 degrees, and if you see that we have apex at T4, we have also apex at T9 and apex at L3, which is triple major, which is the case which is in classification of link type 4. The patient is mature and 13 years old. In these cases, when we have 107, so as you see, it's a completely inflexible curve except in the thoracic, in the lumbar area, and it's a type 3B plus. And we did the anterior, as in this case, we do complete from up to down, and then we close everything down. I do double, in these cases to go up and down, and I do thoracolumbar and double thoracotomy, and this is the end of the case, and this is the correction. This is the patient post-op. Now we have the type 5 in Linke classification, which is the thoracolumbar type. The apex is L1, Reiser is 4 to 5, and is 17 years old. So it's a very 5, sorry, this is wrong, Reiser 5 and 17 years old age. If it is, see, the thoracolumbar is 66 degrees, and the upper is flexible, which is 19 degrees, and the thoracolumbar is inflexible. So we do simple posterior. It's type 5 CN, which is neutral osteokyphosis, and this is also simple posterior correction for the scoliosis. The last case, according to the Linke, which is the lumbar curve, the main one, which is in this case, as you see, 58 degrees, and 40 is about the main thoracic, but if you see the flexibility is going 17, which is minor. So we are selecting only the thoracic, thoracolumbar lumbar curve, and we did our fusion and selecting the distal and proximal vertebra. And at the end, I would like to see that if you are thinking in your clinic, especially for the early takeoff in the learning curve surgeons. So this is the plan to confirm diagnosis of idiopathic scoliosis, how to assess the progression in the low, moderate, and high, to do your follow-up and to do your treatment. Then the need of a treatment, it is for observation or for real treatment, and then to select the treatment if it is bracing or surgery. Thank you very much.
Thank you, Dr. Firas. This was an excellent presentation. Thank you. Any questions?
I want to see.
Hello.
Yes.
My name is Hassan Salhin. I'd like to thank you, Dr. Firas, for this excellent, impressive presentation. I have a question about the case where when you are doing the anterior release and then the posterior surgery. I believe you do these surgeries in 2 sessions. Is this right? Is this correct?
Yes, you are correct. Do
you apply?
Yes, I want to tell you something very important. In
Yeah,
the last, years of surgery, of my surgery, I did before 10 years, most of the cases, the severe cases, more than 70 degrees or 80 degrees with anterior release first of all, and then I send the patient for 1 week, and after 1 week I do the second surgery accordingly.
That was my question. Do you apply any type of traction or physiotherapy between the 2 sessions, or you just believe that the surgical release is enough to get a posterior correction, a good posterior correction?
Never ever I did any traction. Never. I did, even in my, training with Professor Jürgen Harms, we did the for the cases, especially severe cases, we did before, the surgery, the traction in the clinic. So then we did the surgery, but even I didn't use it later on. I believe that if you do just release and you do meticulous release and then you do osteotomy, you have very good. But even nowadays, I told you the last, less than 10 years, last 7, 8 years, I didn't do any anterior surgery. I do all my cases with the osteotomies. And this is, and in the cases of the lumbar, which is in the lumbar spine, the problem is the rotation. The rotation is very, very difficult to correct rotation only from the back in the lumbar spine. So I'm using, nowadays, the Olive surgery in the lumbar to do even release and cage insertion. Then I do minimal invasive scoliosis. Now we are turning more to stop the anterior surgery. We are doing all osteotomies from the back, and we are doing nowadays minimal invasive surgery.
Yes, that was my second question, because I believe the need for the anterior surgery in scoliosis to achieve release will be minimized, because we have new implants and we have very modern implants which allow us to do the three-dimensional correction. My second question is about the minimal invasive surgery. Do you believe in such flexible curves that we can apply a bigger rule for minimal invasive surgery in the future to correct such lumbar curves? We have done about 4 cases in younger kids, about 10 years old. It was a trial, and it is off-label trial. The patients had signed a special consent about this. We do percutaneous fixation, and when needed, just fusion at the apex, but no further fusion. Just applying the rods and correcting the flexible lumbar curves. Wait for 2 years, then remove the implants and do a follow-up. But we don't have a large number of cases, because you have to convince the parents about this type of experience, of experiments. The results were good enough that the curve stopped to progress after we removed the implants, and the only problem was the severe pain the patient suffered from after removal of the implants due to the rigidity and arthritis of the facet joint. Do you believe that something like this in the future will take a bigger role?
Look, about we have to, first of all, to define what's the meaning of minimally invasive surgery. Now, I believe, I'm not doing minimal invasive surgery by percutaneous screws. We are doing a very nice, technique that's less invasive surgery with the small ones, and we're going with approach, if we'll say approach, and we don't destruct too much tissue, and we have very good results and correction. Now, about to do percutaneous, the main, concept or the cornerstone of scoliosis to do fusion. So if you don't injure the periosteum, or if you don't take the periosteum from the bone, so you don't have fusion. If you take the muscles without periosteum injury. So if you, even sometimes, if you do dissection and take the periosteum, you have fusion without bone graft. But if you don't have at all, you have non-union. So fusion is a cornerstone in the scoliosis. This is the first. The second issue for me about, to remove the screws, to remove the later on the rods and the fixation. And there is a lot of studies and evidence, one of them that I know, that if you remove any instruments in scoliosis with conventional scoliosis surgery open, that we do bone graft and do fusion, you have 7% that you have adding on again some deformity. You lose 7% of the correction, and you have pseudoarthrosis, and the pseudoarthrosis is painful. But this is that we know, and in your study and your technique, that if you really do a study, we are waiting your result. It's not bad to think and to start again and to do studies if you can in your institution.
Yes.
If you have result, we are very happy to hear about you. And
I agree totally with you. We aim to do a non-fusion surgery, and as I told you and all other colleagues, it is an off-label study or off-label technique. It is not published, and it was just a type of experiment, and just only 4 parents had agreed with our technique, our trials, and mainly for the lumbar curve, because the thoracic curve is usually more rigid and less flexible than the lumbar curve. The last question, my side, would you think about applying cages like TLIF, minimal invasive technique, in the lumbar curve, just to minimize the amount of fusion? My aim is, if you apply a TLIF, you have achieved anterior release from a posterior approach, and you can stop at L3, for example, instead of doing the surgery to L4. Would you take something like this in consideration?
this is excellent. It's not a question, it's a comment, and I thank you for this. Look, I am minimal invasive surgeon. I have a huge number of lip surgery since 2008 till now. So I told you that we have, I do a type of less invasive, scoliosis, which is, you can name it minimal invasive surgery. And with a group with Dr. Romain Dayer from Geneva in Switzerland. And we have a lot of cases and a lot of series. One of the cases that I do usually, that if it is a lumbar scoliosis, I do olive technique. So I do minimal invasive. I usually put the cage with a small wound, about 2 centimeters, in the L3, L4 as example, L2, if it's severe scoliosis lumbar, L2, L3, and I'm going to L1, L2, and penetrating, the pleura, but there's no matter. And after I do these 3 cages, definitely, as you said, you do release first of all, and you do correction for the rotation. So it's in these 4 levels, I do percutaneous screws. I don't open, because we have a very good anterior fusion by the cages and the bone graft. And then I open small ones up in the thoracic and continue my surgery. So to do really minimal invasive insertion of the cages in the lumbar spine and the thoracolumbar is an excellent technique to do correction and to secure fusion. And then you go from the back percutaneous screws at these levels. You are right.
Thank you, Dr. Faraz.
Thank you, Dr. Faraz, for your presentation. This is Samer Sami. My comment about anterior release also, we used to use this technique about 12, 15 years ago. But as you mentioned, and Dr. Hassan mentioned, with osteotomies now we don't need. Bawachi have a very nice paper mentioning that the curves up to 80 or even 85, you can do just posterior column osteotomies and high density screws, you can achieve good correction. But about the traction, I think with severe curves, if it's actuated with something like neurofibromatosis, traction is very helpful, but we have to prepare the set available to use the traction for about 3 weeks or something in severe, for example, 100 degree curves. This is my first comment. My second comment is the keynotes you mentioned is very, very nice about the shoulder balance and the identification of the neutral and the stable vertebrae. So thank you about it. Dr. Hassan, I have a comment about the percutaneous. I attended something like a meeting in Montpellier with the French people that they do CT-guided pinning for the direction of the pedicle and do percutaneous pedicle percutaneous fixation for long segment just with CT-guided. And they are also convinced about no need for fusion, but also is it off-label. And thank you very much, dear friends.
Thank you, Dr. Samer.
Thank you, Doctor. I agree with you that I don't do more anterior, surgery, and even I have, 34 cases, vertebral column resection that I do rather than I do anterior surgery.
Dr. Faraz, we have another question from Dr. Faware, but until he unmute himself, there's a question from Dr. Saeed. He says it's an excellent talk. What is the incidence of neurological complications in your cases despite neuro monitoring?
We started the neuro monitoring in Jordan in 2008. Really. Before 2008, what's the difference? And after the neuro monitoring, I can tell you, the studies they are talking about, neurological deficit in scoliosis is about, 3%. But with the spinal cord monitoring is 0.3%. But, really, we don't have major cases. I don't have, major, complication like paraplegia as example. Now, to have, some, sensory disturbance, some, radicular pain, this is, you see it in your surgery, but all of these, neurological deficits like paresthesia or some radicular pain, it's not permanent. All of the cases, they covered very well. About paraplegia, we don't have any case of paraplegia. And I can tell you that, paraplegia, even in our, culture, in a small community in my country, or, I'm doing also surgery in Dubai. If you have any case of paraplegia, they know it in the second day, all the country. So you will not continue as a spine surgeon. And this is the main concept of scoliosis. That's why not all of the surgeons like scoliosis. It's a very risky surgery, but if you go in the proper surgical techniques, and and you have a very good training, and you start your learning curve step by step, usually you don't have any major neurological deficit.
Dr. Fras, excuse me, I have another question about the neuromonitoring. Do you do only neuromonitoring? Do you depend completely on neuromonitoring, or do you make the classical wake-up test?
Never, ever. Wake-up test, I didn't do it even before spinal cord beating, this is my technique, this is my way, because it doesn't help you to do something real. But if you're sure that you have a problem, you do a wake-up test. But when you start the spinal cord monitoring, and we do all the cases with the spinal cord monitoring, I don't use wake-up test unless I have, flat, spinal cord monitoring. Yeah, the meaning of this, the spinal cord monitoring indicating that there is a neurological injury. In this case, first of all, I do whatever I do to release about the spinal cord, and the second, I do wake-up test. I want, just to tell you something important. I have some case for also the Dr. Saeed question. Yes, I have cases, especially in the vertebral column resection. And if in the future we can do some lectures about the vertebral column resection. So sometimes you do correction because it's a severe, scoliosis. And you look in the spinal cord monitoring, and sometimes you lose your signal. So, and you can correct again, and the signal come again. And the meaning of this, that's why spinal cord monitoring is excellent to use. So sometimes if you do some correction and you have real, compromise over the spinal cord, or the blood supply of the spinal cord, and the signal is down, it's a very good alert to go again and to correct. And when the signal is good, so you can stop. So the spinal cord monitoring is very useful even during your, correction. But it's not useful if you injure by your hand the spinal cord, because it will give you the signal, and the signal will remain the same. But it's excellent if you do the correction.
Thank you, Dr. Fras.
Yes. Thank you guys for this wonderful lecture. I was late, sorry. I have two questions and one comment. For the guy who asking for about neurological injury, is he mean, I think if he did mean that injury by the surgeon, yes, this will depend on the training, and I agree with Dr. Faras, but always through most of the centers, there is incidence of neurological deficit and scoliosis, or even in spine surgery. My question for you guys, how often do you use costoplasty, which means you cut the ribs because the amount of correction you get from rotation is not enough? This is the first one. And the second one, how much you depend in your shoulder levels in your examination, I mean, to determine the upper level instrumented vertebra. Thank you.
Thank you for, the complication. You are right, Mohammed, and I know that you are also experienced scoliosis surgeon. But, about if you have later, ischemia of the spinal cord, and, sometimes, and we have it in many centers, and I saw it, that sometimes everything went well, and after the surgery, the patient is moving very well. And after the second day, and after a few hours, you have again, paraplegia, and this is ischemia of the spinal cord. That can be happen, but the incidence is very, very, very low. It's not a very high incidence. I agree with you that there is some complication, non-modifiable, that is not from the surgeon. It's from the abnormality of the anatomy, or abnormality of the vascularity of the spinal cord. And I want to tell you that there is evidence paper from France that, you know, the abnormality of the vasculature of the spinal cord is about 33%. It's very high. So I agree with you that there is some, you know, complication that the surgeon is not part of it. But, you know, the anatomy of the spinal cord is the most important cause. This is the comment, and I agree with you. The second about, you know,
shoulder level.
About
shoulder level.
Before the shoulder level is about the reps. You know, it's very important to correct the hump. You know, you know, the problem in the scoliosis that the patient cannot, it's, you know, still immature or adolescent in the age, and he is not too much careful about, you know, the ego or the body most of the time. So the real patients are the family, is the parents. So the first thing that they ask you about the hump. So you want to correct the hump? Yes, you can correct. But, you know, I don't do costoplasty. The meaning of this, that I take the ribs of the hump. This is since about more than 10 years. But what we are doing in most of the case of the hump, you have to do correct rotation. And the only way I do osteotomy, or I take out the head of the ribs at the concave side, and usually from the apex and at least 2 levels above and 2 levels below. And if you take the ribs, the correction of the rotation more easy. You can push all the ribs to the other side, and in this way you correct about 80% of the hump. So this is that we do, but I don't do more costoplasty at the hump itself. We do a head or rib excision at the concave side. And even during the surgery, when you do the rotation, and as one of my colleagues said, that today instruments or equipments, they help you a lot in the correction of scoliosis with the osteotomies. So if you do the rotation in the proper equipments, you see that, you know, the rib that you take, and usually I take more than, you know, 2 centimeters from the costovertebral junction to the rib. So when you do the rotation, the rib at the concave side again reaches its distance at the vertebra. So you have a very good correction of the rotation. Now about, you know, the shoulder river, this is, you know, concept that we have to know that it depends. That usually we have, as example, if we have right, you know, shoulder tilt or left shoulder tilt. So if you have, as example, right, the main thoracic curve, and you have the left shoulder, the left tilt, so you have to determine it is from the proximal thoracic curve and determine the thoracolumbar. So it depends. But usually we have very important way to go in the T4, T3, T1, T2. And this is the maximum. So if you have, as example, left, we go mainly to T2. If we have right, which is compensated to T4, and if you have neutral, so in the T3. So this is the main concept of the shoulder. So it's very important to correct the shoulder, and it depends on the proximal tail, and even the lumbar with the pelvic obliquity, the same. But it's these it needs cases to discuss, and it needs to talk more accurate. And I think the main concept we can do it by case discussion.
Thank you, Firas. We have last 2 questions. One from Osama Dahamshe. تفضل Osama.
Yes. Yeah, thank you guys for this good presentations. And thank you, Dr. Firas, for this talk, which was comprehensive and precise. And actually, I have two simple questions. First question is about the correction degree. Usually in your patients, are you aiming to correct the full correction of the scoliosis, or you, in some cases, you accept less than perfect correction? I would like you to comment on this one, because, you know, there's a growing talk in the literature about the degree of correction and the functional outcome. And the second question is about do you have, or if you can talk, which cases you use the MIS, or which is the indicated cases for MIS or not? That's my two questions for you.
Thank you for, these very important, especially the first question. I told you in the beginning that, in scoliosis, I believe that, every case is unique. It's not, you have to study every case by itself. It has its personality and character. So we have targets in this scoliosis. First of all, to stop a fusion, to stop a progression, which is by fusion. The second, to correct. But look, two things that by the time you will see it very important in your treatment. The function of the patient, which is the meaning of this, the preservation of motion. You can do it as possible as you can. The second issue, the cosmetic appearance, especially in our area, for the females, the cosmetic appearance is very, very important. It's something that the family asking in a way that if the cosmetic appearance is the most important for us. So here you can do the balance. So if you can do 100% correction, it is the better. But if you cannot, due to, first of all, the high magnitude of the curve and the deformity, you can stop in the acceptable, cosmetic appearance. The other, limiting factor for me is the preservation of motion, especially in the lumbar spine. And I have a lot of cases that I would like to share with many of our colleagues, that I don't accept to close the lumbar spine to S1 or to L5. So this is to do compensated spine. If you leave in the lumbar spine curve, even if it is a little bit, decompensated. So I accept, as example, 3 centimeter of the compensation, 2 centimeter or 3 centimeter to compensation, but I give the female a very good function of the lumbar spine for even in the future, the low back pain, for the pregnancy, and for the normal delivery. And this is, you have to include it in your planning of a treatment. But today we are talking about how to think about it, but in proper way, you have to give every case a unique study, a unique plan, and to think about the cosmetic appearance, and to think about the preservation of the motion and the function. And whatever the X-ray, there's no problem, but you have very good appearance with compensated spine. This is the first question about, and the second question, can you just tell me again? Sorry. About minimal invasive surgery, yes.
It's just about, minimal invasive, exactly.
Yes.
What's your indication? Which cases you indicated for MIS?
We do all the cases till about 65 to 70 degrees sometimes, but it depends. It's lumbar, it's thoracic or lumbar. At the thoracic, I have case of 65 degrees that we did. Less invasive surgery, not minimal invasive by percutaneous screws. The less invasive surgery that we do facetectomy, we can do osteotomy, and we can do also rib excision with the minimal invasive surgery, with the less invasive. So it's a conventional with less soft tissue injury. It's not percutaneous screw, the techniques that I'm talking about. That's why we can release and we can correct. And we put bone graft also.
Dear sir, we have another question from Dr. Baranvir.
Hello?
Yes, please.
And that's a very good presentation, sir. I would like to ask one question regarding the rib hump is concerned. When the hump is very close to the midline, for example, if it is thoracic curve, when the hump is very close to the midline of the curve, especially when the transverse process are involved, how do you correct that kind of hump? And when the hump is very far from the midline, especially when the ribs are involved, you already told like just above the 2 levels above, 2 levels below, you want to remove the ribs, especially on the concave side. But I would like to know when the hump is very close to the midline, what is your approach?
Yes, we about the hump, from our basic concept about the hump, there is rotation of the vertebra. That's why the hump is going up and the other way is going to be low. But there is the permanent structural deformity of the rib that we have to know about it. So if it is still in the beginning, it's in the patient, as example of adolescent age, about 10, 15, 13, 14 years, still the structural, and if it is not too much, it's about Reiser 3, not Reiser 5 as example, is not completely mature. This structural sign of the rib is less. So what's the meaning of structural sign? In the hub, that there is prominence of the vertebra posteriorly, but if it is permanent, there is acute angle of the vertebra. If it is not, it is a benign curve. And in the concave side, the vertebra is completely straight. There is no any curve in the concave side. So both of these cases, the main concept is the rotation. So in both cases, what I do, I take, sometimes this is very important. If you have very big curve, very big, hump, the meaning of this, it has severe rotation. The meaning of this, that you have high magnitude of the curve. So I take the head of the rib from the concave side, and usually I open the costovertebral joint. And this is, the rib from the concave side is joining the two vertebrae, especially if you go from up to the T9, T10, the rib is doing joint, the costovertebral joint is doing joint of both vertebrae. So if you want to release even the joints in between, you have to take the head and to release the costovertebral joint. In this way, you can rotate. If it is in severe scoliosis and severe hump, which is medial, which is the transversal process, you see it in this case, so you need more, release for the costovertebral joint to rotate and to cover the transversal process from the hump side. And then that's, I told you that sometimes you didn't correct completely. Sometimes you have 70% or 60% according to the structural or permanent deformity of the rib itself. So if it is acute, the permanent, so you have less correction. But if it is benign and curved, you have more than 80% of correction of the hump in the head rib osteotomy or excision at the concave side.
Thank you, Dr. Firas. Our last question, for the sake of the time, for Dr. Armouti. What about the long-term follow-up for early onset scoliosis? Do you see an increased incidence of degenerative spine disease at earlier age? I mean, after follow-up for scoliosis surgery?
Yeah, sure. That depends on the where you stop. So if you stop at maybe 4 or 5, so definitely we will have early onset L5S1 degenerative disease. It depends on the curve that remained. If you still have maybe 20 or 25 degrees of the lumbar curve, that may lead also to degeneration as early. If you have a straight spine and selective thoracic fusion, I think the risk will be much, much lower. So how much you fuse from the lumbar spine, how much the curve remain, this is the main player. But I agree, there is a higher risk for degenerative spine after these surgeries in 40s and 50s years.
Yeah, that question was from Qusay Saleh from Jordan University Hospital. Thank you, Qusay, for your contribution. Finally, I would like to thank our speakers. They were magnificent. There was an excellent presentation, excellent explanation, and that was an excellent interaction between all our attendees. Thank all our attendees for their presence and their questions, and please stay safe and be well, and we hope to see you soon. My last announcement, we have another webinar going on in like 1 hour from now at 9:15 our time, 8:15 Egypt time, and it will be about endoscopy group webinar from Egypt. And I advise all of you to attend it. I will send it on the WhatsApp group for the registration. Thank you all wish you all the best.
Thank you very much.
Thank you.
شكرا يا شباب، بدعتوا.
حبيبي الله يعطيكم العافيه.
بدعتوا فعلا، بدعتوا محمد وفراس.
الله يخليك، شكرا حبيبي والله يعطيكم الف عافيه. بس انا تفاجات انه ما شاء الله عندنا انترناشونال كويس، يعني لو بنعرف كان
والله انا بصراحه يعني I was not expecting that.
يلا كويس الحمد لله رب العالمين. يعطيكم الف عافيه. ثانك يو ابو حميد. يعني انت
كيف كانت الامور؟
بحكي انا وياك بس سكرت المواضيع اللي انا بدي اياها عشان اكمل. برافو عليك، شكرا.
كويس،
الله يعطيكم العافيه.
الله يعطيكم العافيه.
يلا سلامات.
يلا احنا النكست عندنا الاثنين الامتى؟ الخميس للدكتور
احد.
طارق.
احد، وفي عندنا الاثنين مع ايجيبت ان شاء الله رب العالمين.
مع ايجيبت كان في كيس ديسكشن. ويل دون، ثانك يو فيري ماتش. يلا السلام عليكم.
يعطيكم العافيه يا شباب، يعطيكم العافيه.
اسامه خلينا نسمع اخبارك يا اسامه حبيبي.
اكيد بنضل على اتصال.
اوكي ابعث لي تليفونك في نيويورك.
اوكي
ايفون.
مش عارف شو اللي صاير، مستنى.
يعطيكم العافيه.
لا انا لانه كان عندي محاضره اونلاين، بعطي محاضره على الكمبيوتر، خلصتها قبل دقيقتين، بس خليني اطلع على الصور مضبوط واحكي معك تليفون، شو رايك؟